Quiero continuar con la presentación del doctor Yasahuri Okuda. El doctor viene de la Universidad del Sur de Florida, de Estados Unidos de Norteamérica. Él es líder reconocido internacionalmente en educación y en capacitación clínica basada en simulación. El doctor Okuda es el director ejecutivo del Centro de Simulación y Aprendizaje Médico Avanzado. También se desempeña como el primer director ejecutivo de la programación de simulación de educación interprofesional de la USF Health y es profesor de medicina de emergencia en el Departamento de Medicina Interna de la Universidad del Sur de Florida. En su función como director ejecutivo, lidera la Dirección Estratégica General del CAMS, este Centro de Simulación y Aprendizaje Médico Avanzado, y aprovecha sus fortalezas existentes identificando las nuevas oportunidades de crecimiento y supervisando las operaciones diarias de este centro. Hablando en el sentido de la participación al respecto de la inteligencia artificial, las nuevas tecnologías, la innovación, pues tenemos a un gran experto con reconocimiento internacional. Welcome, Dr. Okuda. This is your home.
Buenos dias. I'm going to take this off. This is going to be in English, so I apologize. Well, first, I'd like to thank Dr. Carolina del Carmen Ortega for the invitation to speak here. I'm very honored to be here. I had the opportunity back in August to visit your beautiful simulation center in this building, and I was so impressed with the work that's going on across IMS and the other simulation centers focused around patient care and patient safety. Following up on the conversation of Dr. Kirsanovich, I think, in the ideal world, I would love to see the preventative medicine really expand so that, me as an emergency physician no longer have a job, right? Nobody coming to the emergency department because people are sick. But I think in the meantime, we, as he mentioned, with all of the increased technologies and information, we really need to move forward to innovate in how we do education and training. I'm going to talk a little bit about what that future looks like. And I think innovation and education can be done both in preventative medicine, but also in sick care, so diagnosis and treatment. So first, I would just like to see, just get a sense of who you all are in the audience. Just if you could raise your hands if you're physicians, if you're a doctor. Can I see? Okay, wonderful, so many. How about nurses? Okay, also very many. Pharmacists, there's a few pharmacists out there. And then other healthcare professionals. Wonderful, thank you. And how about educators? People that do education and training every day. Okay, so many of you. So first, I just want to thank all of you for the hard work that you do every day. And as you go through your days this week and going through all of the education and speakers, a lot of this will fall on your shoulders to help improve the care of your nation, which is a big responsibility, but also a really great privilege. So I thank you and I applaud you for that. So I'm going to try to give you some background on the future of healthcare simulation. I'm going to use a little bit of my notes. I asked my team to translate this into Spanish, but then I realized I can't read it. So I have a little cheat sheet here that's in English that's going to help me through this. So first I want to tell you a little bit about who we are. We are the Center for Advanced Medical Learning and Simulation. Our simulation center is 8,300 square meters in size in downtown Tampa, Florida. We're set up as a non-for-profit under the University of South Florida, which is a public university. And we have many different capabilities. We have what we call a bioskills lab, where we do training for surgeons, where we use cadavers to train on things like trauma, resuscitation. We do training for the military as well using cadavers, and also teaching surgeons how to use advanced new emerging technology for procedures like robotic surgeries and other things. We also have a mannequin-based simulation center, which focuses things like team training, communications, procedural skills as well. So we have 32 surgical skill stations, and we have 18 outpatient rooms, and we have 5 inpatient ICU emergency rooms and a trauma room. Our mission is to create and provide experiential learning that improves clinical skills and patient care in our community and around the globe. And our vision is improving healthcare through lifelong education and training. So today I'm going to try to give you a sense of my vision of the future of healthcare education. We'll talk a little bit about what simulation is and discuss its role in healthcare education, and then how we integrate healthcare simulations into medical training. And then I'll talk at the end a little bit about emerging technologies for training and education, including things like augmented reality, virtual reality, educational gaming. So first, to give you a little bit of background, so I think anytime you hear somebody say, talk about the future, I think it's important to understand the lens that I'm talking to you through. So a little bit of my background. I trained in New York City at the Icahn School of Medicine at Mount Sinai. This was over 20 years ago. I spent 20 years in healthcare simulation and training and education. And I helped start the simulation program for the medical school and for the residency program. Soon after that, I went to the New York City Public Health System, which is the 11 hospital system in New York City that provides care to 1.4 million patients in the city, employing over 45,000 individuals. And if you can see up in the top, IMSAL is the Institute for Medical Simulation and Advanced Learning that we built, and it was up in the Bronx in Jacobi Hospital. And we really tried to do training at that center to the other 10 hospitals, and there were a lot of successes, but also some challenges. From there, I went to become the director for the Department of Veteran Affairs, where we have 174 medical facilities, over 1,000 clinics, and we care for 9 million veterans, and we built a center, a national center for the VA, and that model was a train-the-trainer national center, and then we delivered simulation at all of the VA medical facilities. So that gives you a little background on my lens. I was so excited to come and speak to you all because you have, I believe, a very similar type of opportunity and some of the challenges where you're really caring for over 70-80% of your nation's population. You have hospitals throughout the country, and I believe you have already 3 simulation centers that are throughout the country, and with the future of building many more. So what is healthcare simulation? There are many definitions. I like to use Dr. David Gaba, who I consider the grandfather of healthcare simulation, that it's a technique and not a technology to replace or amplify real experiences with guided experiences that evoke, replicate substantial aspects of the real world in a fully interactive manner. So again, like the military, like aviation, you don't want to train when you're fighting, or you don't want people training in flying your airplane. You don't want a trainee. And so they practice in simulation environments. And I think healthcare, when I trained, we practiced on patients, but I think we're moving in a direction where we're starting to practice in a simulated environment, which I think is really important. You can see Dr. Lorena there. He's our medical director and trauma surgeon. He spoke yesterday. So I want to talk a little bit before I get into the future. When I say simulation, what kind of technologies or tools that I'm talking about? So simulation includes standardized patients or actors. And at Camels, we have over 150 actors that are trained to be patients, family members, children, so that we can train our future healthcare doctors, nurses, pharmacists to communicate better for our students and future workforce. We also have many task trainers that are used to focus on specific procedures like placing central lines, A-lines, lumbar punctures, and we do utilize a lot of these task trainers for our trainees, our residents, our fellows, and students. In addition, we have advanced procedural trainers. So these are things where a physician typically can practice how to do angiography, robotic surgery, colonoscopy, and these actually will assess, evaluate you, give you feedback, and depending on how well you do, it increases the level of difficulty. So you could do basic training as well as advanced training. In addition, mannequins have become very advanced nowadays. They come in all shapes, sizes, and colors, representing different backgrounds. We have birthing mannequins. We have trauma mannequins that can do amputations, require tourniquets, and some of our mannequins are so sophisticated, they breathe out carbon dioxide and breathe in oxygen. And if you actually reduce their oxygen saturation will go down. They'll eventually go into a cardiac arrest. So very sophisticated mannequins. And then some of these newer technologies like augmented reality, virtual reality, mixed reality, and I'll talk a little bit more about that later in my talk, are some of the areas that we are actually researching at USF Health Camels to see where they fit into training and education for both our current workforce, our students, as well as future workforce. So those are the technologies. So when I start talking about simulation, just consider those as the different tools that we can use. But I'm going to shift a little bit now into the use of simulations for improving healthcare, patient safety, quality improvement in large health systems. And this is information over the last 20 years that I've dedicated to healthcare simulation, education, and training, using different technologies and modalities. So first, simulation is such a powerful tool for improving patient safety and the quality of healthcare. And as I mentioned in my earlier example, it's very similar to when I flew over here. I flew in Air Mexico, and I was very comforted that likely the pilots were training in a simulated environment, and they probably have to do that once or twice a year to ensure that they can handle difficult situations that they normally wouldn't handle. I traveled before I came here. I was up in DC. One of the airplanes got delayed. It hit a bird, the engine failed, and it had to land. And the power of simulation is, even if they've never done that before in real life, they were able to go through simulations, and so the pilot was able to land it in a very safe way. So simulation, where I see the most power, is in areas around patient safety and quality of care. So I'm going to give some examples. And so the first example is using simulation for difficult conversations. And I think, I was really inspired by Dr. Krasinovich's talk this morning, and thinking about how do we improve the knowledge of our patients and their family members for preventative medicine. And as an emergency physician, I have very little time to spend with patients. I think in the US, they spend 5-10 minutes with their patients. And so, how do we retrain our doctors to be able to spend time with our patients, having conversations about diet, smoky cessation, motivational interviewing. Those are the powerful aspects of simulation so that the students can learn, even the current doctors and nurses can learn how to apply these techniques and practice, because it's not easy and it's not necessarily always intuitive. In the US, we do simulations on difficult conversations around diagnosis, to tell somebody that they have a terminal illness, to tell somebody that their family member has passed away. And so these are really powerful uses of simulation. Another area is new procedures and introduction of new technologies. So you can see if you are starting to introduce ECMO, extracorporeal resuscitation, maybe your hospital is introducing robotic surgery. For me, when I was training in emergency medicine, I learned how to intubate using, direct laryngoscopy, and they introduced video laryngoscopy into the emergency department, a glide scope. And how I learned how to use a video laryngoscope was when the salesperson came, they brought some pizza, and then they taught us how to use it, and then now it ended up in the emergency department, and I had to use it on patients. None of the attending physicians wanted to use it because it was a new technology, but then the younger generation kept pushing and saying, this is great, we should be using this, and now I had to supervise residents or trainees where I had no expertise in the technology. So again, using a simulation center to practice both at the experienced physician level or nursing level on procedures before going into patient care. The third area that simulation can be used, it's very powerful, is high-risk, low-frequency events. So these are, like I mentioned in the pilot example, the pilot hitting a bird and the plane's engine going out. So what does that look like in healthcare? And you can probably think of a lot of different examples. As an emergency physician, it's a crike, difficult airway, cannot intubate, cannot ventilate. So I'm going to show you a little video that we've started supporting in Tampa, Florida. And so how many people here have been to Tampa, Florida? Not that many, okay. So Tampa, Florida is in the middle of Florida on the west coast on the water. And we have, you'll be surprised, one of the best ice hockey teams in the world in Florida, where it doesn't snow. And the Tampa Bay Lightning, they've won the Stanley Cup, which is the highest honor, multiple times. And I'll show you the video first, and then we'll show you what we did.
Now to that scare on the ice, the hockey star collapsing on the bench during a game, and here's ABC's Diane Macedo.
Tonight, the frightening scene at a hockey game.
There looks like Bowmeister just drops right behind the bench.
St. Louis Blues number 19, Jay Bowmeister, seemed fine on the ice.
Number 19 at the blue line.
After a few minutes of play versus the Anaheim Ducks, he returns to the bench, then collapses. His teammates frantically wave for help, and paramedics rush in, using a defibrillator to revive Bowmeister, as both teams watch in horror.
So this is an example, as you can see, of a player who had a sudden cardiac arrest, and the team had to go, the paramedics and the doctors had to go address and resuscitate. Infrequent, but high risk. I'm sure here you can think of examples in football or other sports examples. And so we partnered with the Tampa Bay Lightning because we wanted to make sure the players were taken care of in the best way possible.
Hello, how you doing? not saying anything. We may have to get an airway on this guy, so let's get ready to roll.
The purpose of today's training was to train emergency physicians, Tampa Fire Rescue, and the team trainers for the Tampa Bay Lightning in how to respond to on-ice emergencies for hockey players who get injured.
Inflate it for me.
Do you guys feel like that's where we want it to be?
It's a great relationship with our organization, our owner, Mr. Venig, and USF and the Kamloops Institute, and we're extremely lucky to have them nearby literally in our backyard to utilize this simulator and kind of take it to the next level, real life situations.
Without here helping. CPR.
This is really exciting for us to be involved in this. From my understanding, maybe there's only one other simulation center that has actually partnered with a...
Oh, the video went. So that's an example of, we do this every year now to train their teams in these high-risk situations. Cardiac arrest is one of them. Apparently another injury is they wear ice skates, and so there are situations where somebody had a skate go into their neck, their arm, and they're very sharp and they get bleeding. Head injury, as you can imagine. So very different ways of, did the PowerPoint freeze? Very different ways of having major injury in their hockey environment. As you can see in the video, that was my pre-COVID hair. I had a little spike, and then COVID happened. You couldn't get a haircut, and so I moved in this direction. My children also said that it was too young, so I look like this now. Is the slide deck freeze or the computer freeze? There we go. Okay. Hopefully we keep going. All right. So the next area is rehearsal. So you can see on the bottom left, that's from one of the children's hospitals in the US where they did rehearsal of separating conjoined twins. And they went through all of the aspects with every team member. It can't just be the doctors. It can't just be the nurses. It's interdisciplinary. It's interprofessional. Everybody coming together, rehearsing the whole procedure so that they can be successful in the real separation of the conjoined twins. So rehearsal can be very powerful for simulation, as well as skills degradation. So again, somebody like me, I teach lots of students and residents. When was the last time I did an intubation, a central line, a lumbar puncture? It may be a long time. If you have really good residents that's always successful, then they're going to be putting it in all the time. And sometimes your skills may come down. So the ability to go into your simulation center, to re-practice your skills, maybe you learn how to do a central line before ultrasound. And now everybody's using ultrasound. So now you can go in and practice how to use ultrasound in a simulated environment instead of on patients. And then team training. So I'm going to give you a video example of team training. So as I sort of just mentioned, it's so important to train in the teams that you practice in. It's not, you need more than just one profession, doctors, nurses. You have to train the whole team. And so we do those types of training. That's kind of our specialty at Camels, and I'll show you a video. Maybe the video disappeared. Oh, team training is at the end. So I'll show you that in a second. Human factors training. So we actually, when I was at the VA, the Department of Veteran Affairs, they opened 4 brand new hospitals across the US. There was in Las Vegas, Orlando, Denver, and New Orleans. When you open a hospital, most places you open the hospital and you hope everything goes okay. It's brand new, patients come in, you do your first operation, and before simulation, you couldn't practice the OR to make sure it was safe, all of the procedures in the new hospital. And so what we did was, when I was working for the VA, we brought a team and we ran simulations both in the outpatient and in the inpatient setting to ensure all of the safety issues were addressed. And over a year, we found over 300 different possible latent safety threats, possible risk areas that they were able to address before they opened their doors. So testing your hospital system, if you're opening a new emergency department, a new clinic, using simulation can also be very, very powerful. In situ simulation, so we do code training, ACLS, BLS at the center, but then we'll take our team and then we'll do mock codes in the hospital to again practice the teams coming together to ensure they work well together, but also to make sure the system is working properly so that the proper pagers or phones are being, pagers, I sound old, the phones are being activated, ensuring the best possible care. Procedural competency, so again, I mentioned this, we train, Dr. Lorena spoke yesterday, we train all of our incoming residents, our trainees, on central line before they go into their hospitals in July. They actually have to go and pass a test. If they don't pass a test, they get remediated. And so we know that all of our incoming, the ones that just graduated medical school, starting as interns or residents, are competent in placing central lines when they place it on patients. In addition, there are centers in the US, children's hospitals, that'll use their simulation center to train family members. So they'll bring in family like a mother or father and teach them how to do trach suctioning, do ostomy care, so that, because as you heard this morning, a lot of the family members are taking care of our patients. And it's scary to see your child or your grandchild, with a trach and, it's the sounds coming from it. And so they'll use simulation centers to train their family members so that they feel confident and competent to care for their children. And then team training. So I think the team training was the video I was trying to show. So this is another team training. We have emergency doctors, residents, nurses, and paramedics in this training for handoff.
CPR's advised. Okay, so we got a 52-year-old male, witnessed cardiac arrest. He was working out at the gym when he went down. There was bystander CPR upon arrival. When we got there, he was in VTAC. You got one shock on scene. Right now, he's still in VTAC. You got one epi on the way there. You got a 20 in the right AC.
All right, everybody clear? Shock.
End of scenario, guys.
Today we had one of our graduate medical education training programs, the emergency medicine program, come in to do training around rare emergency scenarios. What was unique about today was that we had Tampa Fire and Rescue and we had nurses from Tampa General Hospital participating in this team training event.
So we had multiple cases, including pediatrics to adults to cardiac arrests. We learned about individual pathologies, but also more so about team building, working in teams.
Especially in the ER, it's a team sport. I mean, we have doctors, nurses, techs, paramedics, students, pharmacists, it goes on and on. So learning how to interact with people with different backgrounds and different important roles in the team is really important.
If our members of those teams don't communicate together and help each other in understanding what the needs of the patient are, and if they're siloed, it leads to a lot of the problems that we currently have in our healthcare system: high costs, poor communication, errors in medicine. So simulation is a powerful tool that we can use for the better of our learners, but especially for the better of our patients.
So in the US, you would think after simulation being implemented in large healthcare systems for over 20 years, all the hospitals would be using simulation, but unfortunately that is not the case. The US, I believe, is falling behind other countries that are really coordinating the use of healthcare simulation across large health systems. So as I mentioned, we do use simulation in the New York City Public Health System, the Department of Veterans Affairs, but in the US, in the other private and public hospitals, it depends on which hospital you go to, the requirements for simulation. So we've been working through the Simulation Society to engage with government, CMS, hospitals, to require simulation-based education and training for hospital and healthcare systems. Last week I was up at Congress talking to congressmen and congresswomen, but we still have a long way to go in the U.S., and I'm very excited to hear how far you all have come and the opportunities, since you are the largest and the public health system in Mexico. Most recently, the first requirement for simulation or drills that has come is through the Joint Commission in the US, and this is only 2 years ago, where they require simulation for reducing maternal mortality. Twice a year. They require drills now for hypertension, postpartum hemorrhage. But again, this is after decades, and they're just starting to make some requirements in the use of simulation to ensure patient safety. So shifting gears a little bit, other areas where simulation can be very powerful as large healthcare, large systems or population for disasters. And so as you continue to hear in the US, we have a lot of mass casualty events, whether they're shootings, bombings, or other activities. And so at Camels, we've actually developed training to help small hospitals, their frontline healthcare teams, to prepare them for caring for mass casualty incidences. A climate crisis, so we partner with the military to conduct drills for evacuation, for hurricane, et cetera, when those situations hit. When I was with the VA, we actually used simulation to test our hospitals to see if they were prepared for accepting patients with Ebola. And then during COVID-19, in Florida, we benefited from about 2 months before the COVID surge hit. And so up in New York, as you probably heard, when the initial wave hit, people were dying. One of the hospitals I trained at in Elmhurst, Queens, received, I think, a large number of COVID patients. And so in Florida, our doctors and nurses were watching this happen in the news, and a lot of fear and anxiety was starting up in our teams. They started building protocols of how they would intubate, how they would do cardiac arrest, but none of them were tested. They're not evidence-based. They were based off of anecdotes in New York, Italy, other places that they were hearing of situations happening and their healthcare providers getting sick. So we partnered with our academic hospital, Tampa General, and we built out simulations to train. We trained about 500 doctors and nurses before the surge hit Tampa. This was around April and May of 2020, and our teams went into the hospital to train the teams on the COVID protocols. And I have a video of that.
We did a simulation on what we call a Code 100 here, which is when we have a patient who has COVID-19 and they get critically ill or need life-saving interventions, and how that kind of shifts from what we're normally trained in doing. It's a change in who responds. It's a change in how we protect ourselves when we go in to try and save somebody's life when they're in that kind of episode. With the Camel Center and what USF training and what we use when we're in medical school and in residency training, we brought that here to TGH. It's such a unique opportunity.
It's that safe place to practice and be okay with making mistakes and figuring out how you can improve your care, not just for our patients, but also protecting our team members, because we are human.
We're all working together to try and adjust how we do our job so we can take good care of these people and be prepared for the worst and hope for the best, and that these measures that we're taking are going to help.
Watching these nurses and providers go from that high level of anxiety and fear because of the unknown to then being more confident. And I think that is the key here, is that these simulations has really set up our team members to be prepared for whatever is coming their way. We could not have done this without the help of Camels and USF.
So if you saw in that video, you probably noticed that the team was in the room, and then outside the room, there were people out there. And so traditionally, when you run a code, you have all the team members in the room, respiratory therapists, pharmacists, nurses, physicians from critical care, hospitals, etc. But our goal was to keep as many of our providers out of the room, away from the patient, and only have the necessary people in the room. And the idea was they were going to communicate using walkie-talkies. And what we learned early on is they've never used walkie-talkies before, and it was very difficult to communicate the needs to the teams outside. And so we practiced this so that they would have language to communicate if they needed the pharmacist to prepare drugs. They would have the drugs, they would bring them in, certain people would go get them. And so it helped reduce the level of stress, fear, and anxiety, which you heard from one of the nurses, so that when the patients came, our healthcare providers and professionals were safe and they felt safe. So a few more slides just talking about the use of healthcare, the use of experiential learning simulation in education, and then I'm going to switch a little bit to talking about new technology. So for our students, we utilize simulation for interprofessional education. So we have colleges of nursing, pharmacy, public health, and medicine, as well as physician assistants, CRNAs, many other professionals. And what we're trying to do is have them work together early on in their training so that they understand what the roles are for each of those professionals. When I learned as a physician, I went to medical school. I never worked with nurses. I went to residency training, and I worked with them, but I didn't really know what their roles and responsibilities were, like nurses and pharmacists. And it was only until I graduated that I had to work in teams, and that's not very effective. So at USF Health, we try to integrate simulation-based education and interprofessional education early on in their first years or second years so that they work together. Interprofessional practice is another area. So this is more on what you saw, the team training that we did with the doctors and nurses to help them learn how to work together. My dean says that medical knowledge is doubling every 43 days. I think you heard some of that this morning. And in addition, we're reducing time that our residents are spending in the operating room taking care of patients, so they see less and less sick patients. And so the use of simulation-based education can be a very powerful tool. We have to do things differently in training and education. Teamwork and communication, as I mentioned, teaching about leadership and how to lead teams, and then working in things around diversity, equity, inclusion, and then, as I mentioned earlier, procedural skills. So I'm going to shift gears a little bit and talk about, so those are areas, and I'm sure there are many others through my experience over the 20 years where I've been able to integrate healthcare simulation into different aspects of patient care, quality care, or training our workforce. I'm going to shift a little bit now and talk about some of the emerging technologies and maybe some of the evidence behind those. So first, I want to talk about extended reality and educational gaming. And so when I worked at the Department of Veteran Affairs, we collaborated a lot with the military, the Department of Defense. And I learned at that time that the military was using serious games, is what they call it, to train their medics and corpsmen. They're the folks that go with the soldiers to place the tourniquets, to place the crikes, to resuscitate their soldiers and Marines. And it was engaging and effective for teaching some of the knowledge and skills, and not the actual skill, but the steps and the equipment. And so they utilize educational gaming to train these individuals up, all the way up to the special forces. So educational games can be very powerful. If you have children at home, or if you yourself are a gamer, you know how addicting gaming can be. Right? People think they're going to play. One of my daughters is a gamer, and she's like, "Oh, I'm just going to go play for an hour," and I don't see her for a few hours. right? I myself am also a gamer, so I'm guilty of that as well. But can you imagine if we can harness that motivation into education, right? So if we can get our future workforce to play games, serious games, to at least learn the knowledge and some of the skill components before they go in to practice. It's a lot easier than reading a 500-page book. You have to do that as well. But we have a new generation of learners that are coming up that have much more discrete attention spans, and we have to be innovative in the way that we provide the education. So these are two examples of very simple games. So the prior one you saw was much more advanced looking game. The one on the left, and I use this as an example, I don't know if it's available anywhere. Stanford up in California built it, and the game is called Septris. And so are you all familiar with the game Tetris from many, many years ago? The little blocks coming down, and so that was very addicting, you know, like the box, and you're trying to get rid of the rows. So they combine the idea of Tetris with sepsis education. And so this is, again, on the left side, you can see the faces of the different characters, and they come from the sky, and you get to know their background. And then before, when they were doing sepsis management using a bundle, they had to resuscitate that patient so they get better and move back up. And then another patient comes down, and it gets very addicting. You have to, and that helped the learners understand the algorithms in sepsis management back then. Very simple concept, but it's much easier than reading this in a book or watching a PowerPoint presentation. The game on the right is a game that we developed when I was at the VA. And this is, I don't know how your hospitals work. In the VA, we have over 150 hospitals. Each hospitals, at least when I was there, had code carts, crash carts, but they were allowed to configure them, so, you know, put the meds in the airways. They were not standardized. So depending on what hospital you went to, there are different ways that the crash carts were configured. And so the easiest solution to that is standardize it, but they couldn't do that. So as educators, we built a game that you can customize based on your hospital and your crash cart configuration, and then you can learn where all the drugs, equipment are within your hospital using this crash cart game. And so you have a doctor saying, I need epi, I need this, I need that, and then you have to make sure you know where and which drawer it's in. So those are examples of games, and I'm gonna shift a little bit into extended reality. And before I get into it, I'm gonna talk a little, just kind of orient you. So I'll talk about virtual reality and augmented reality mainly. Virtual reality is, you put on the headsets usually, and it's on the right-hand side, the white ones, and it could be of different colors, and you are fully immersed into your environment. You can't see outside of the glasses, and you interact with your environment. It's almost like a movie, but you have controllers, and you can pick up things and really engage in the environment. It can be very realistic. If you play some games that are scary, like Resident Evil, they jump out at you, it's really scary. Augmented reality is a little different, typically also with glasses or goggles, but you can see and interact with your environment around you. So I would be able to see a table, I would be able to see a mannequin. And so augmented reality overlays images into the environment around you, and so that, you know, if I looked at a mannequin, they might be able to overlay the organs onto the mannequin so you can see through the mannequin. So I'm going to talk a little bit about both of these modalities briefly. So here's an example of augmented reality, right? This is a physician. He's in an actual ER room at his hospital. He has headsets on, and he is demonstrating some training.
Now, if you don't... I don't feel good. Family brought him in.
So his head injury, you can look at his pupils. One of the pupils is dilated. He's able to apply a C-collar. You can start seeing him posturing. And you can have the vital signs are in the background, and you can engage using assets that is superimposed onto your clinical environment.
Jeff, are you okay?
This is an example from the outside what it looks like. And so you have this gentleman interacting, like he looks like he's just playing in the air, but he actually sees the different things in his environment. He's posturing down because there's a patient on the ground, and then he uses the little tablet for all the vital signs. So this is an example of augmented reality. This is another example of augmented reality. This one you don't need goggles, but they're interact. It's a little hybrid. So this is they're doing an oophorectomy. If I could forward it, you would actually see smoke coming. It starts bleeding. You do cautery, etc. But what's interesting is there's haptic feedback because they actually use a piece of rubber and they overlay the images. So if you see the white box, that's actual laparoscopic equipment, and the little rubber piece is in the box, and they look on the laptop and they overlay blood, smoke, and other things on top of it, and you can tell it actually, you can use data to see how efficient your movements are for trainees, and they can even take these home. So what is the evidence in virtual reality? We still have, or augmented reality, sorry. We still have a long way to go. I think it's starting to show some evidence in the surgical procedural realm, and on health education, often it's soft skills. So like talking to people to learn communication, anatomy, clinical reasoning. So I'm going to shift now to virtual reality. So now you have a headset, you're fully immersed, and this is an example of some team training. And these are people in different locations.
All right, hello, I'm Dr. Cohen. What brings you here today?
So all of those 4 heads are different people wearing virtual reality headset working in the common environment, and they're working on the diagnosis and management.
Let's just assign roles. So, Christine, I would like you to be the tech.
So the team leader in the orange or yellow at the foot of the bed, and then the team members are all there, but they're all sitting at home doing the training. Okay, and so virtual reality, similar, good with procedural skills, training education, things like anatomy. But again, this is an area that we're studying because we want to know, where does virtual reality, augmented reality truly fit in training and education? So I have a human factor scientist, and we're actually doing research on this right now with multiple grants. Last few slides, I'm going to talk a little bit about haptics. Haptics technology is basically, when we talk about things like virtual reality, it's easy to say, well, how are you going to learn how to put a central line in a virtual environment? You need to feel the needle. You need to feel the skin. And it's not going to teach you that, and I agree. But now with haptic technology, where you can actually wear gloves, that when you pick up a scalpel, you feel the weight of it, you feel the pressure of it, that's going to take it to the next level. And so we're actually we bought a pair of new gloves that it's coming out on the market. We're going to try to do research on the haptics as well. This is an example of me wearing the original prototype where it's tethered. Now it's on a backpack, so it's a lot easier. And you can see the level of sensitivity of the glass. I've never worn these gloves before. I put them on. I was able to operate robotic arms that you can see. I'm in a virtual environment, so I can't even see what's going on. I see an image, and I was able to pick up a puzzle piece. And on first try, like a real person, I was able to fit it right into the puzzle. So the level of technology, you can imagine the possibilities in the future for rural medicine, surgical procedures. It is very exciting, and so we're trying to do some research on this as well. Finally, you can't talk about emerging technologies without artificial intelligence, training and education. We are pretty new into this at Camels. We did do one study where we actually looked at all of the open source generative AI language, image, and sound systems to see if they were ready to be, if they were good enough to develop simulation-based education and training, create cases to be voices of patients where you're interacting with or represent clinical environments. Very small study, and it really showed that it's not there yet. We have a presentation in the International Meeting on Simulation in Healthcare in January in San Diego that we're presenting the results on. But again, we're still very early, but the technology is moving very rapidly, and I'm sure in the near future we're gonna be utilizing this quite often. And then most recently, we actually purchased a technology where they use the large data that's focused on patient conversations to practice interviewing skills. There's a company out of Australia that has this new technology, and so we purchased it. We're going to do some research on that as well. So hopefully we'll have more information in the future. So that is the end of my presentation. Please, we are pretty active on social media. You can see the new things that we're doing. And it's been a pleasure to speak with you all, and thank you again for the invitation.
Thank you so much, Dr. Akuda. First, I want to thank you for your effort to presentation in Spanish, for the slides. Thank you very much.
Oh, my pleasure.
We appreciate.
Oh, my pleasure.
Do you please let that the public make some questions for
Yes,
you?
please.
Yes. Okay. Bueno, buenos días otra vez a todos. Alguien, por favor, si tiene alguna duda, pregunta, comentario, aprovechar unos minutos con el doctor Okuda y su participación.
And it can be in Spanish because I can hear it.
Sí, él tiene la traducción lista para las preguntas que puedan hacer. No tengan miedo, no lo tienen que hacer en inglés. Por allá andan micrófonos. Allá en medio hay una mano levantada, por favor, muchas gracias.
Okay. First, I would like to congratulate you on your excellent dissertations.
Thank you.
My English not is very good, but I want to try to do the question in English. Usually, people, when working with object and machine, tend to act to the cold and mechanical way because they are just an object. And my question is for you, what strategies do you use to prevent your student from developing this behavior and probably this human care?
So and the speaker is a little hard to hear. What was the...
¿Lo puedes preguntar si gustas en español y la traducen, por favor?
Okay. ¿Qué estrategias usualmente cuando las personas trabajamos con objetos, con máquinas, trabajamos de forma mecánica, de forma fría? Entonces, mi pregunta es, ¿qué estrategias utiliza para que sus estudiantes que están recibiendo ese entrenamiento no proporcionen un cuidado deshumanizado?
That's a great question. So first, a lot of it has to do with, there's a whole process for delivering simulation where a lot of your success for a good simulation requires a good pre-briefing. And so we talk about a lot of different topics before the students go through the simulation. One of them is psychological safety. So we say, you're here to learn, We want you to make mistakes. We know you're here to do the best you can, and we're not going to judge you. We're not going to make fun of you. We want you to be fully immersed. The second thing we say is we sign what we call a fiction contract. And so what I often say to my learners is, we're not going to be able to replicate the mannequin or a task trainer like a real person. And if you're seeing a real person, it's going to feel more realistic, especially for experienced healthcare providers. But we're going to do the best we can to create an immersive environment that makes it the most value to your education. But we need you to also try to use your imagination, engage as though it's a real person to the best of your abilities. Similar to when you go see a movie, you don't want to be next to the person saying, that's not real, that's fake, that makes the movie boring. We want you to fully engage. And then on top of that, we'll typically use our mannequin simulators, the machines, and we'll create an environment that feels very real. Sometimes we'll throw in sounds. So we did a recent training for our ambulance crew, and one of the scenarios was at a pool where they picked up a little boy who was drowned, and they came to the scene, and this was outside, and we had all the pool sounds that you would hear in the background, so it feels real. And then we also had actors that was laid on as a mother to really engage the learners. And then we put on moulage so that they saw the injury patterns on the individual. And we interviewed the learners afterwards. One of the paramedics said afterwards, I actually forgot I was in a simulated environment. I thought I was at a real poolside. So those are some of the tools that we use and really engage our learners.
Gracias, doctora Kuda. ¿Alguien más tiene alguna pregunta? Por allá el doctor, ahí.
Mi nombre es Samuel Quintanilla y gracias por compartir.
Doctor, acérquese el micrófono, por favor.
Mi nombre es Samuel Quintanilla.
Gracias.
Soy médico familiar y profesor en Nuevo León. Y mi pregunta es, ¿cómo podemos cambiar la idea errónea de que la simulación es solo posible con modelos de alta fidelidad en un país en donde los costos son no muy accesibles? Gracias.
So that's a great question. Definitely, I think there is a misconception. You don't need the most fancy equipment to do simulation. Some of my best simulation was early in my career in the pediatric emergency department, where I used the doll as the patient, and my students would be around it. And then I used my iPhone to show the vital signs, and that was just as engaging. So yes, I don't want to give the impression that you need all this high technology to do great simulation. Some of our best simulation, if you look at the records, nurses used to give injections with an orange. That's simulation. One of the first birthing simulators was about, I think 150 years ago, with just a doll that was created on how to do different birthing techniques. So it's more that's why the definition, it's a technique and not a technology. So I appreciate you bringing that up, absolutely.
Gracias, exacto. La simulación no significa la alta tecnología. La simulación es simular un escenario de la realidad y hacerlo pues justo lo más real posible para tener un escenario de aprendizaje, ¿no? Y ya vimos también cómo la simulación se puede hacer a través de equipos de trabajo. Cómo las simulaciones no usar solo robots o alta tecnología o realidad virtual, sino que también se puede utilizar esos escenarios de simulación para el trabajo en equipo, para promover competencias y habilidades blandas. Doctor Amaro, por favor.
Gracias y me uno a la felicitación de tan flamante ponencia. Mi pregunta, bueno, primero quiero informarles que igual los centros de simulación del Instituto Mexicano del Seguro Social estuvieron trabajando durante la capacitación del personal en el momento del COVID. Y estuvimos manejando el uso correcto de los equipos de protección personal, intubación con ellos y también competencias humanísticas como la atención médica humanizada dentro del COVID. Porque como usted comentó, había miedo por parte del personal para la atención del mismo. Mi pregunta va a lo siguiente, y creo que va relacionada con la pregunta que hizo el doctor anteriormente. ¿Cuál considera usted que sea la importancia de capacitar al personal docente sobre el uso de la metodología de la simulación clínica? Porque no es lo mismo usar un simulador creyendo que estamos haciendo simulación clínica que utilizar de manera correcta la metodología. Muchas gracias.
A wonderful question. Thank you for asking that. So first, again, congratulations. The simulation programs at IMSS is amazing, and I'm not surprised that you were able to integrate it during COVID, which is wonderful. So you're absolutely right. When I started in simulation over 20 years ago, I assumed that it would be similar to what we do at bedside teaching. It's very different. One of my most embarrassing moments was when we were doing a simulation demonstration in an audience like this, and we wanted to showcase how you could run simulation, and we did a demonstration on the table, and we pulled up a really well-known professor to help with the simulation, and he ended up lecturing for about 15 minutes in front of the simulator, right? And that's not simulation. And so there are professors that are all very skilled in didactic teaching, lectures, et cetera, that may not be as skilled in simulation, and vice versa. And so what we've done in my various roles that I've had in my career is built instructor courses for simulation. And we built 2 tiers, 2 levels of professors. One is the tier that is very knowledgeable in simulation. I've gone through in my career probably over about 80 or 100 hours worth of simulation-based education training for debriefing alone. And so we try to train a core group of faculty that are expert at debriefing, about giving pre-brief and how to do proper debrief to not make the students feel embarrassed and use it appropriately. But not all of the professors have time to do that, or maybe they're only teaching once or twice in the simulated environment. And so for those individuals, we'll do short, 4-hour, just really understanding what's important in simulation. 1 hour or 1 day, we've done 1-day training where we focus on the really critical skills needed, show examples of good simulation and not so good simulation. So hopefully they'll go into the environment and really sort of reflect on how they're utilizing simulation for training education, because it's definitely not the same. And again, I really appreciate that question.
Muchas gracias, Dr. Okuda. Un aplauso, por favor, para el Dr. Okuda. I want to give you a little gift. This is our logo of the Mexican Institute of Social Security, and we are glad to have you, and we have a lot of things to do in the future. Thank you.
Thank you so much. Agradecemos la valiosa participación del Dr. Haru Okuda y hacemos entrega de su obsequio y reconocimiento.